Yes. Thank you so much for the invitation. I'm really honored. This one, right? Okay. Very good. Excellent. So I think this session is great, and I'm so honored to have the possibility to speak among friends here. I hope my English with Italian accent is easy to understand for all of you, right? So I have no conflict of interest. So I made a bibliography search before coming using TB migration, etc. And it came out that there are over 6,000 articles published, a lot. So it's really difficult to summarize this in half an hour. So I will try my best. The majority of the papers have information on treatment, on screening, and few on treatment results or yield of screening, which are the issues which are more important for us. So I will briefly touch the issue of what are the myths on migrants and which is the reality. And I will discuss briefly some nice historical memories of migration and screening, which are useful also for our own planning. Then we will see which are the screening options for TB and LTBI. And Katerina already introduced the topic and presented something that is very useful because we can go a bit more quick on that. We will see migration and health or lung health, and a little bit on research priorities. Okay, this is the action framework for TB elimination. So 8 main areas. And we see the core areas are migrants and vulnerable populations. In a way, they are more or less same category. And the management of latent TB infections. Those are the main areas which are interested in. And then if we focus on managing TB disease, then we do TB control. If we manage LTBI, as Katerina has correctly said, then we work on the TB elimination, let's say, perspective. This is a famous picture from Sao Paulo, no? So from here we have the rich people, probably very little TB, and on the other side of the wall, probably we have a lot of TB, right? And migration and poverty are interlinked, and migration is global. So we have migration ever since the beginning of human beings, and we will discuss more, but that's really a big problem. In terms of language, a migrant is any person who is moving, regardless of the legal status, if it's moving voluntary or involuntary, which are the causes of it, and the length of stay. The asylum seeker is an individual seeking international protection, and the refugee is the person who meets the criteria. So every refugee is initially an asylum seeker, but not every asylum seeker will ultimately be recognized as a refugee. This is a problem. So we have many asylum seekers, but then few of them will be recognized as refugees. And what about the others? So shall we send them back home, etc.? So this is one of the key issues we are going to discuss. I try to group some of the core questions here. Migrants keep increasing. Is it true or not? Is TB increasing in Europe due to migration? Is true or not? Are foreign-born non-adherent to treatment? Is it true or not? Do migrants transmit TB to the local population? Is true or not? Those are some of the myths. So are migrants increasing? Basically, it's not fully true because there was a peak in 2015, 2016 in Europe, but in Greece, they are increasing. You will see why, because the situation is very, very flexible, is changing every month, let's say. Is TB increasing in Europe due to migration? Basically, in Europe, TB is declining. Katerina has shown the slide. And the RS globally a little bit increasing, particularly because of the former Soviet Union countries. Foreign-born are the majority in some countries, but not in all. And we have seen in Greece, they are a bit less than half, some 40% or so. And the rates of TB per 100,000 in Europe are stable globally. Okay, this is not meaning that migration is not important, but those arguments are used by politicians when they want to make Brexit or they want to divide the countries, or it's a typical argument which is used politically, the fear of migrants. Is it true that foreign-born are not adherent to treatment? We will see that in some countries it's the opposite. This depends so much on the ethnicities. So some populations are compliant, others are not. There is no evidence of transmission to the local population, and I'll explain this a little bit better. So this is the situation in Europe, and we see that Greece is number one now. Italy was number one, but now it's number three. And we see this is Greece, and we see there are waves there, but Greece now is number one hosting the countries. More than 100,000 since January, and I think Katerina has shown this also, but those are the countries, Afghanistan, Syria, etc., which are more contributing to the burden. Why Italy has become number three? Because we had a government, a certain moment, very strict, which says we accept the ship with the migrants only if Europe shares equally. And then Europe was saying, no, we don't want. Okay, so this is Dutch ship, okay, back to Amsterdam. This is German ship, so back to Hamburg. That's the point. I don't fully agree with that, because that was sometimes tough, because we had mother, children that were fished from the water, was in bad shape, etc., etc. But the concept that we have to share resources and have a European collaboration is an important issue. And honestly, I don't think that these countries have been supported much from Europe, both economically and politically, right? So if you are invaded military from somewhere, then Europe will immediately intervene. But when we are invaded by migrants, we are not helped that much. This is just my own bias, but okay. So let's see the story of the increase due to migration. So basically, there is a reduction in numbers, except for MDR, and it's not really true that migrants are, let's say, the reason of the increase. It's interestingly a bit alarming that there is an increase on TB HIV. This is very much due to what is happening in Ukraine and Russia, etc., etc. But it's a phenomenon which is, we have seen this already, the decrease in Europe, and we have seen what's going on here in Europe in terms of proportion. And we see this is Greece. This is the proportion over time of migrants over the total. This is the stable situation as far as the numbers per 100,000 population, which are between 3.4 and 3.9 per 100,000 in Europe, more or less stable. That is quite a lot, by the way. Yeah? Okay, this is interesting. Maybe you have not seen that slide. I have to thank Andrei Dado from the regional office who gave me the slide. So the triangle are the compliance, the adherence of the migrants, and those are the natives. And we see that in Cyprus, in Czech Republic, in Finland, etc., in Germany, in the green countries, the migrants do better than the natives in terms of adherence. So they are more adherent. And in the red countries, that's the opposite. This depends on the ethnicity. For example, in Milano, we have very good adherence by Peruvians. The Peruvians are more than 95% success rate, because there are mediators there, and when they told them, please follow the rules, be treated, they obey, they comply. With Chinese, it's a disaster. So the Chinese live and die without no one knows, and they have their traditional medicine. So the success rate in Chinese born is very low. So it's really a very puzzled situation. In this systematic review on MDR, the estimated adherence was 71%, and there was no difference between migrants and non-migrants identified. And those are other studies which shows some different findings in the different countries. In Germany, better the migrants, and etc., etc. This is the situation in Milano. We were discussed this paper yesterday during the dinner with Caterina. And basically, this was a thesis which has been published in the European Respiratory Journal very recently. And on top of demonstrating that the screening with X-rays worked well, the paper shows that the TB treatment success of asylum seekers in Milano was very high, and the acceptance of LTBI treatment was extremely high, 92%. We have to say that this clinic is a special clinic which has an ancient tradition and is equipped with visiting nurses. So there are nurses who go out, they have vehicles, and they follow the patients up at home. So they have this outpatient model, which is one of the reasons explaining why these excellent results have been achieved. Are migrants transmitting TB to the native population? So according to this systematic review that we made with ECDC in 2014, there is very little effect. So the transmission is bilateral, very little and bilateral. Sometimes migrants infect local, and sometimes the local infect the migrants, but it's very little because they tend to live a little bit separately. This is what we know. So we cannot exclude this. This might always happen, but it's not a big phenomenon. A little bit of history. We can go quickly on this. This is the big migration 120 years ago, where our grandfathers made Brazil, made United States, and made Australia, New Zealand, etc. And there were very many Greeks, very many Italians, very many Germans, etc., etc., etc. This is the migration that took place between 1870 and 1940, and was mainly a south-south migration from India to Caribbean to Africa to South Africa to Malaysia. And there was also the migration here in the East, in China, etc., which was important. And this was the big migration after the Second World War that still have influence. We see it still in look into the strains and the molecular epidemiology. So the big migration from former Eastern Europe to Western Europe to Israel, very much. A lot of MDR was coming from Russia to Israel. And then the big migration following division of India, which was really one of the reasons which created transmission in that part of the world. And if you look to the map of the world, we cannot pass through all of this, but more or less everywhere there are problems. And I took 2 minutes for a couple of examples. So in Latin America, Venezuela now is in crisis, and there are so many migrants. So all the countries around Venezuela are having problems with these migrants coming, et cetera, et cetera, et cetera. And this is the United States, and the president there wants to build walls. He's building walls everywhere too. So, you know, to prevent that Mexicans can pass there, and the Mexicans say, okay, you build the wall and then we will pass down, right? Okay, just another 3 examples that are interesting. So in Russia, in Moscow has an incidence of 20 per 100,000, rather low, almost, Moscow. Huh? There are about 5 million people every day which from outside Moscow come to Moscow and go back. And they come from Central Asia, so Russian-speaking poor countries, basically. And this brings TB back and forth, and they live in dormitories, et cetera, et cetera. So we are studying the phenomenon. It's complicated it's very little is known on that. Another example is this of the rich countries of the Gulf. You know, if you go to Abu Dhabi or these countries of the Gulf, there is petrol, they're rich. So they have a lot of migrants who are imported, let's say, to build the roads, the infrastructure. And in some of these countries, the population of migrants is 2, 3, 5 times higher than the native Arabic, right? And they have more latent and more TB. So when they want to eliminate TB, then they should decide to screen and treat all the latently infected individuals. And they're a bit hesitant because the population is large, so they need to invest quite a lot of money. The last example, I go quickly, is Bhutan. I'm not sure you are very familiar with Bhutan. I was not. We made a course this summer. Bhutan is a kind of countries, like in the tales. They have Minister of Happiness. They live very, very nice, very beautiful. And they border with India. And they have several thousands seasonal or daily workers, which every day come from India to Bhutan and back in the evening, which bring MDR in back and forth because Bhutan has very little. Yeah. But they cannot control much because they have no regular contracts and they simply pass back and forth. So those are just examples on how difficult it is to control this planet of migrants. So this is the situation we have in some parts of the world with informal slums and settlements on the routes for migration. Those are some of the transit cities in Africa. And those are the routes towards Europe, and those are the routes that passes to reach Greece, and even to Greece and Italy and Spain, etc., to proceed to Nordic countries, to Germany, etc., where majority of these migrants want to go. This is the big London, right? And if you look to the incidents in London, you see that it's completely different from all the rest of the UK. It's like a full other country. And this incident is that high that we have in New Delhi or in Karachi. Why? Because the red areas of London are basically composed 90% of people from these cities. So if you go in some of these areas, then you see a real British every 10 people, right? And the incidence there is very high. And this poses issues, specific issues. How do we control this in these specific areas of the city? Okay, this is interesting. This is Dubrovnik. It's a picture I took from entering the harbor of Dubrovnik. This was ancient republic, right? And then they created, several centuries ago, a quarantine structure. It was kind of hotel, pretty nice. It was not a prison, it was more like a hotel. All ships coming from Far East, etc. They were obliged, everyone knew, so it was quiet, to enter the building and stay in room number 1 for the first week. So those who had no sickness were second week next room, third week next room, fourth week next room, fifth week out, and they were able to go out that way and enter the city. And this was the first known example of systematic quarantine. Everyone was supposed to do this, was quiet, they were well nourished, etc., etc., etc. It's pretty interesting. The building is still there. This is a paper we published, I think, in 2013 or so. And it's pretty interesting. There are two things I want to comment. Okay, this is what was happening to our grandfathers in Ellis Islands in 1917, when our grandfathers were arriving, right? So they were looking for 2 diseases at the time, TB and syphilis, right? Syphilis. And syphilis had, at the tertiary level, they were crazy or they had neurological problems, right? So they were obliged to run stairs very steep with their luggage, right? So on the top, there were people observing. So those who were coughing and laughing, they were screened. Coughing because probably there is TB behind, and laughing because if in this situation you laugh, it means you have a mental problem, right? And on the top of the stairs, there were medical women and men, doctors, which were screening the people. So this is a first systematic known model, very economic, very cost-effective, to screen for the 2 major diseases. It's pretty interesting. So that's why I think it's useful, maybe not that we have to do this, but can give us some ideas. Okay, in the publication here, there are some issues which are of interest. Basically, we can have a pre-entry or a post-entry screening, these two models. And there are pros and cons for this. And of course, the screening of latent is very important if you focus on TB elimination. And the paper reports the experience of Switzerland, I come in a second, how they have created a score system to decide if everyone should be screened or only some ethnicities, right? We will see this in a second. Okay, so this is the model. Pre-screening, then migration post-screening, and then we can screen for TB or for latent. And then if there is transmission, is a case, then we do contact trace, then we activate also this branch. Which are pros and cons of this? Those are the different places where we can screen on arrival, airports, reception centers, migration centers, etc. And this is what we can do at the level of post-arrival screening. There are so many different things, including contact tracing and active screening, as Katerina has presented before. There are clearly advantages and disadvantages. Just a few comments. Radiology is very good. Katerina has shown it. There is a clear advantage with gamma interference, with IGRAS, let's say, at least because the majority of migrants are already vaccinated. So the BCG vaccination is covering, and if you do it with MAN2, we are never sure whether this is because of the vaccination or the positivity or because it's a real infection. And then soon there will be a new quantiferon independent. So I'm not paid by quantiferon, unfortunately, but they've created a new test which is very cheap and very easy to use. And this will be even cheaper than the MAN2. So I think in the future there will less and less doubt of which test to use. Again, screening with latent is sometimes a bit difficult to organize. And the problem is that it's sometimes difficult to convince people to be treated for latent when they are not diseased, but only infected, right? So that's why the American invented a treatment of infection and non-chemioprophylaxis. It's the same thing, but say that you treat for something seems more important than just preventing, right? So Americans are very good in these things. Okay, I think Katerina presented the yield of screening, and I think we can go on. We don't know much on this, and there is very little which compares the pre-arrival versus the post-arrival yield of the screening. It's clear that if you target populations which are higher risk, then the yield is higher, right? And here I want to tell you a little thing, which is, if we have 2 minutes. Okay, the first is anecdotal, right? When I was Secretary General of the ERS, I don't know if Mina Gaga is in the room. No, she's not. Then I was invited with Jürgen Vesbo, he was president at the time, to Canada. So for a conference, we were invited by a Canadian conference. Then we had to do this kind of ESTA, is the permission to enter the country. And then I know the story. So I declared I had no contact with TB patients because I knew the story, so no problem. And then Jürgen was a bit naive, and then he said, I'm a doctor, so he crossed that. And then he was obliged to undergo the screening, right? Can you consider how crazy it is that in Denmark, someone from Denmark is screened to go to Canada when the risk in Denmark is much lower than that in Canada? It's completely crazy, but this is the rule. Then he said, okay, can I do the X-ray in my own hospital? No. The only way is to go to the family doctor, which has the contract with the government. That was not even in the capital, so you had to take the train, go there, pay quite a lot to be X-ray and visit and say, okay, he's fine, he can go. So he got his document. And then when we were together, when we arrived at the border, then he passed, and then he was stopped because the doctor was lazy and has not yet transmitted to Canada that Jürgen was okay. And unfortunately, he has the documents with him. But they stopped him because he has to show, no, please, but I did it, I'm fine, so they allowed to go. All this is completely crazy, right? So how to, let's say, concentrate our screening on populations which really have a higher risk in a way that the yield makes sense? And I want to tell you before we reach the slide of Switzerland, this is the Switzerland, right? Okay. That Jean-Pierre Zellweger and a group of Swiss were asked by the government to create a score method that gives points based on different things. So which is your country, which is your age, you have symptoms, et cetera, et cetera, et cetera. This is updated every few months. So Syria, okay, there is war in Syria, so the score increases because the risk increases. So it's something that takes into account the incidence in the place, if there is war, if there is any risk factor, etc. And when a person comes to Switzerland, then they evaluate all these parameters quickly. They create a score, and they screen only those who have more than that amount, the threshold points, okay? And they demonstrated that with this score system, they reduced of 9/10, so they screened out 1 out of 10, right? And they only missed 2 cases in a single year they made in parallel. So they say the sensitivity and specificity is very high. Of course, they miss a few, but this reduced a lot of the burden. And this was complicated to do, but it was an interesting model conceptually to try to screen the ethnicities which need it. This is Switzerland. This is the experience of the Netherlands, right? Katerina has presented the experience on TB disease. This is the experience on latent. And on latent, you see, they screened 719 people in this paper here. 25% were infected, 84% initiated treatment, and 87% of those who started completed treatment. This means it's possible. It's possible. Netherlands is a special place. It's small, and they have funding. There is KNCV, which has funding and power to do things, not like a normal scientific society. The government gives them the power. It's like the government here gives to the Hellenic society the, let's say, the mission and the money to control TB in Greece. So they are the technical branch recognized by the ministry. That is a good idea because one thing boosts the other, right? It's an interesting model. But this is to say that it's possible, at least in some countries. Quickly, the migrants have a lot of problems, not only TB, and they need continuity of care. And we need also capacity to speak with them. So we need mediators, right? And this is a study done by ECDC, which look at all the possible disease, not typhoid, cholera, hepatitis, leishmaniasis, etc., etc., all the conditions, malaria, that migrants can bring in, right? And which is the important of the differential diagnosis. We know cough is important for us for TB, but there is a planet of disease behind the screening of migrants, and this should be also kept into consideration. This is an interesting paper that shows that in some of the European countries, there is an increased proportional MDR coming from Eastern Europe. So it's clear that you have the same, that we have the same, that this pattern of migration transmits strains which are pretty dangerous. And this is an example. This is Thailand that received MDR from Myanmar. So this is a global thing. And this is an interesting story of a cluster of MDR TB coming from the Horn of Africa, which basically has been found in different European countries. So some transmission occurs, of course, although it's not a big phenomenon, but it might happen and can be important. We made ERS recommendations a couple of years ago with focus of ensuring timely, free screening without stigma and universal access, etc., etc., etc. This is very important. If migrants fear to be screened, then they escape and they continue to transmit. So I don't think it's a good idea, as some governments are doing, let's say to say, oh, free access is only for local. That's wrong because the people transmit. Okay. This is a result of a study we did. Katerina presented the last one, which was just published, the picture of what is going on at the programmatic level. This is a bit older studies, which was looking to what kind of screening is done for TB, LTBI. And we see that Europe is a puzzle. So someone is screening for both, someone is screening for no one of the two, someone is screening either or, right? So each country is doing differently. And what we can summarize here is that each country has more or less a different model, that we know very little on ill of screening. We know more on TB and much less on latent, that just few countries are equipped to really have a register for latent and managing latent infection seriously. And then the screening basically is based on X-ray, also on questionnaire screening, and sometimes on bacteriology. So, okay, just a few other slides, and I'm going to conclude. This is the document we produced with the WHO Office of European Office. And those are some of the minimum package components: governance, service delivery, surveillance monitoring, and support. And in terms of service delivery, it's clear that proper diagnosis, treatment, prevention, and continuity of care are the priorities. And these priorities are reflected also in the priorities for research, where on top of looking which models are the better to screen, to prevent, to diagnose, to treat, etc., we need also to have research on health system and health economic research, on social protection research, and on health and human rights research. And understanding a bit what Katerina said before, that Greece does not have a real national tuberculosis program, even Italy does not have, because this is the result of the disruption of the national programs which occurred in the 70s, 80s, when the incidence started to go down, that government considered not necessary to keep a vertical system. So we have to keep the integration, and but keeping ahead. It's like a brain, small unit is necessary to run things, to take decisions. Otherwise, TB will escape again. Some answers, I'm going to conclude. This is the Edetect TB projects that you might know. It's a European funded project. And there are some pilots here: the outreach for diagnosis, the migrant detection, prevention, and treatment, establishing database on migrant TB screening in Europe, supporting national TB control programs. And, I go back to this, I want just to report a kind of funny things that happened for this work package here. Because in the Netherlands, they built a radiological bus with a very high technology machine built in the Netherlands, etc., that needed more than 1 year to be approved in Romania. You know why? Because as Romania had no criteria, no rules for the protection from radiation from a mobile, new generation, very modern and very innocent machine, then they blocked it because they thought this can be dangerous. So a very high tech with very amount of radiations was blocked for 1 year, when in the majority of Romania, they still use very old machines of the 50s, which are bombing tons of rays, etc., etc. So this is to say that sometimes it's really difficult even to do simple things. Another two things, which are answers that we try to give as Global Tuberculosis Network. One is the TB Consilium. The TB Consilium is a service which works for free, email-based, that in 2 days allows you, in different languages, there is not the Greek, but you can do it in English. If you have difficult case and you want an opinion, 2 experts will answer your questions and help you for free in 2 days. Feel free to use it, and this is the address, tbconsilium@gmail.com. It works in different languages, and this will be soon the system which will independently evaluate if the BPAL regimen will be possible to allocate. So all those who will request for that regimen will be passed to the Consilium. We will say, yes, it's rational. And then, so this is just to know. It's not yet official, but it will probably operate from January. The second thing is a global project that we are implementing as Global Tuberculosis Network on migration. It's a Delphi questionnaire that will be sent to over 3,000 healthcare workers, so a big thing, with educational and research objectives in 5 languages. We have the Chinese as well, but not the Greek, but you can do it in English or in Chinese if you like the Chinese, right? And the questionnaire is easy, less than 10 minutes to do. It is supporting a large project, and this is the link, and Katerina and Apostolos have the link. So if someone is interested to participate and fill it in, ask to them, and then they will send you the idea is to see what people do and think in different areas of the world on how to screen, how to prevent, how to treat, how to diagnose the migrants. So let's conclude. We have discussed some of the myths, and we have seen that some of them are not really reality. We have discussed advantages and disadvantages of pre- and post-entry screening options for TB and latent. We have seen that migrants have several health issues beyond TB, that the diagnosis and treatment of latent TB are core if you have the TB elimination in the radar, that we have several research priorities related to treatment and et cetera, and continuity of care is important. And then we need free access, sensitivity of service, transborder collaboration, and all this is necessary to improve adherence and treatment outcomes. So thank you very much. Things are not sometimes as they appear, and Efcharistias, right? Okay.